Welcome to this deep dive into the physics, anatomy, and clinical execution of facial revolumization. Because, well, clinical practices completely shifted from just chasing superficial wrinkles to recontouring the entire face.
Yeah, it's a totally different ballgame now. I mean, before you even think about unboxing a syringe for a patient, you really have to understand the underlying physics of how a specific gel behaves under tissue stress.
Right, you need to know exactly what happens mechanically once that synthetic product is actually integrated into the human body.
Exactly, because understanding those physical variables, that's what separates a mere technician from a true clinician.
Let's get right into that rheology then. The two massive variables dictating your clinical outcome are G', which represents the gel's elasticity or lifting ability, and complex viscosity, usually denoted as H star.
Right.
So think of G', like placing rebar in concrete.
Oh, that's a great way to put it.
It provides that rigid structural scaffolding you need for heavier lifting. High G' agents retain their structural integrity under heavy mechanical shear. I mean, they actively resist deformation.
They do, and the rebar analogy holds up beautifully. But remember, this is rebar that has to withstand the dynamic shear of a patient smiling, chewing, and speaking, 10,000 times a day.
Yeah, constant movement.
Exactly. So you want these high G' products placed deep. Calcium hydroxylapatite, or CaHA, is your classic high G' example.
Right.
Because of that extreme elasticity, it really belongs resting directly on the periosteum or in deep sub-Q planes. You use it to volumize the malar eminence, augment the mentum, or fill out a hollow temporal region.
Because you need that absolute resistance to deformation to physically project the overlying heavy tissue.
You hit the nail on the head.
Meanwhile, low G' agents, they belong in superficial wrinkles, the tear trough and the lips.
Right, they don't resist those dynamic muscular forces the same way.
No, instead they stretch and move continuously with the tissue. But here is a practical question regarding complex viscosity. In real life, does injecting a stiffer, highly viscous, high G' product mechanically fatigue your hands more during a long clinic day?
Oh, without question. Higher viscosity and higher elasticity naturally demand a much higher extrusion force from the injector.
Yeah, that makes sense.
If you're staring down a fully booked Friday clinic, pushing a stiff gel through a narrow bore needle isn't just an annoyance. It's a genuine occupational hazard for your hands.
And it throws off your touch, right?
It fundamentally alters your tactile feedback. But, you cannot compromise on product selection just to save your thumbs. You have to match the rheology to the anatomical requirement, period.
Let's talk about hyaluronic acids and longevity, because a common pitfall is assuming the HA concentration alone dictates how long the filler lasts.
Yeah, that's a huge misconception.
Raw HA actually degrades in the body via native hyaluronidases in a matter of days. It is the proprietary molecular cross-linking that binds those chaotic chains together into a durable three-dimensional matrix.
And it goes much deeper than just the total amount of cross-linking, too. The critical factor is the ratio of fully bound crosslinkers to pendant crosslinkers.
The partially bound ones.
Exactly. A pendant crosslinker is only chemically attached at one end. It just hangs off the chain and doesn't provide any true structural stability to the matrix at all.
So if you have two HA products with the exact same concentration printed on the box,
the one with the higher ratio of fully bound crosslinkers will give you a significantly more stable, longer-lasting clinical result.
because those pendant links are essentially just dead weight inside the syringe.
Total dead weight, yeah.
Here is the key point regarding particulate fillers, though. You have to strictly respect the 20-micron threshold for particle size.
That is so important.
If the microparticles are under 20 microns, local macrophages recognize them as foreign debris. They easily phagocytize them and trigger an immediate adverse inflammatory skin reaction.
Right.
You are essentially injecting an immune trigger.
Exactly. You need smooth particles larger than 40 microns. At over 40 microns, they evade macrophage phagocytosis entirely.
The cells are just too small to eat them.
Right. The immune cells physically cannot engulf a sphere of that size. So that allows the product to sit quietly and integrate into the tissue matrix without sparking a chronic inflammatory cascade.
And shape matters just as much as size, doesn't it?
Oh, absolutely. Particle shape is huge. Smooth microspheres integrate seamlessly, whereas irregularly shaped polymers cause constant microtrauma at the cellular level.
Which leads to simmering chronic inflammation.
You got it.
So that occupational reality and physiological cascade perfectly dictate how we categorize the actual arsenal of materials you're using. We group them by how they physically interact with the tissue.
Right.
You have your passive replacement agents, mainly the HAs. Heavy biphasic HAs like Restylane L, Perlane L, and Juvederm Ultra Plus give you that robust structural support.
Right. And while the heavy HAs rebuild lost structure, your light has, like Prevail Silk and Bellatero, serve a totally different purpose.
You reach for a cohesive polydensified matrix like Bellatero when you're injecting very superficially, right?
Exactly, because its uniform integration is your best defense against causing a Tyndall effect.
Right, the Tyndall effect being that bluish hue you get when light hits the skin and undergoes Rayleigh, scattering through a superficially placed clear gel.
Yeah, a cohesive matrix prevents the gel from pooling into lakes under the thin dermis.
Once we move past passive replacement, we get into active biostimulatory agents. These don't just sit there. They actively recruit the body's own fibroblasts to build new tissue.
CaHA, or Bossis, is the real workhorse here. It provides immediate one-to-one volume correction from the aqueous carrier gel.
But then what happens?
Over the next 12 to 18 months, as local macrophages slowly dissolve that carrier gel, fibroblasts surround the exposed CaHA microspheres. They create a dense new type 1 collagen matrix.
Wow. So you are essentially replacing synthetic volume with the patient's own autologous tissue over a year.
Exactly. Polylactic acid, or PLLA, commonly known as Sculptra, requires a totally different approach, though.
Right, because that requires an off-label reconstitution.
Yeah.
You're taking the lyophilized microparticles and mixing them with anywhere from 5 to 24 cc of sterile water, right? Depending on the exact anatomical zone you were treating.
The dilution ratio is critical there. You use a tighter, lower volume dilution for deep structural support and a wider, highly diluted wash for broad superficial collagen stimulation across the cheeks.
And the PLLA triggers a controlled subclinical inflammatory response.
Yes, which stimulates fibroblasts to produce massive amounts of collagen over several months, giving you a gradual correction that easily lasts up to 2 years.
It's exceptional for panfacial revitalization in an atrophic, severely volume-depleted patient. We also see biostimulation with LAVI, which is cultured from a patient's own post-auricular punch biopsy, and of course, platelet-rich plasma, or PRP.
Right.
And then cross the Rubicon into the long-lasting or permanent category. Silicone, injected very carefully in microdroplets where autologous collagen capsules form around them over 3 months.
Yep.
And PMMA Artifil, which uses 30 to 50 micromicron smooth spheres suspended in bovine collagen. But let's be real for a second.
Okay.
Given the entirely unpredictable nature of facial aging, isn't placing a permanent filler like silicone or PMMA a massive clinical liability for a surgeon down the line?
Oh, yeah.
I mean, the face drops, bone resorbs, but that permanent filler stays exactly where you put it.
That pushback is entirely justified. Honestly, it is the central debate in aesthetics right now. Permanent fillers mean permanent potential problems.
Because the scaffolding of the face changes.
Exactly. As facial skeletal support diminishes, maxillary resorption occurs and superficial fat pads descend. A bolus of PMMA placed perfectly on the zygoma at age 40 will often look like a completely misplaced, palpable nodule by age 60.
So you have to counsel your patient aggressively about these long-term anatomical shifts.
You really do. Temporary and biostimulatory agents give you the crucial flexibility to adapt to the aging face over decades without leaving inert plastic spheres in shifting tissue.
That long-term tissue descent brings us directly to the anatomy itself. The face does not age as one cohesive unit. It's not, a single balloon slowly losing air.
No, not at all.
The face is more like a quilt, where individual pockets lose their stuffing at totally different rates.
That's a perfect way to visualize it. Subcutaneous fat resides in discrete, highly compartmentalized zones that age completely independently.
Right.
You will often see a patient present with severe mid-face hollowing and malar deflation, but their nasolabial folds and jowl fat are completely intact or even hypertrophic.
Because of the ligaments.
Yes. Dense fascial septa and true retaining ligaments, like the zygomatico-cutaneous and masseteric cutaneous ligaments, separate these compartments. They completely alter how volume shifts and falls over time. The ligaments are the structural trees, the fat pads are the leaves.
Here's the key point for anyone holding a syringe. Augmenting the deep medial fat compartment, or the pyriform region, indirectly pulls up and fixes the nasolabial folds in the tear troughs.
Always.
You treat the mid-face to fix the lower face.
If you just chase the nasolabial hold by injecting directly into the crease, you ignore the root cause of the volume loss.
You end up giving the patient a heavy, simian, unnatural lower face.
Exactly. By restoring deep volume to the middle third of the face, anchoring directly on the periosteum, you redrape the tissue laterally and superiorly. You reestablish the structural tension of those retaining ligaments.
Even when assessing an aging upper face or evaluating brow ptosis, restoring deep temporal and superior orbital volume can provide a mechanical lift that neurotoxins alone simply cannot achieve.
Exactly right.
To get that precise anatomical placement and smooth integration, often need custom formulations. You do not have to use the product exactly as it comes out of the box.
No, you really don't.
Mixing CaHA with 1% lidocaine allows you to perform variable dermal and sub-Q injections without losing that critical G' lifting power. You're altering the viscosity without sacrificing the elasticity.
Altering the rheology at the table is a crucial surgical skill. Take the tear trough, for instance.
Oh, that area is notoriously unforgiving.
Right, due to the exceptionally thin skin and complete lack of subcutaneous fat. But you can take Restylane L and mix it 1-to-1 with 1% lidocaine.
And that lowers the complex viscosity significantly.
It transforms a stiff gel into a fluid wash. It allows for incredibly smooth, uniform deposition on the periosteum. It practically eliminates the Tyndall risk and prevents extreme post-procedure edema in a highly vascular area.
Knowing exactly where to place those custom formulations dictates exactly how you physically push the product through the needle. Let's dig into injection technique and ergonomics. You have to match your hardware to your Rheology. Highly viscous HAs demand a 27-gauge needle.
It comes right back to the physics of extrusion force. According to Poiseuille's law, when you decrease the radius of the needle, the resistance to flow increases exponentially.
Right, so if you try to push a heavy, highly cross-linked HA through a 30-gauge needle,
your extrusion force spikes.
Yeah.
You completely lose your tactile feedback, your handshakes, and your anatomical precision is just gone.
But easily extruded, low-viscosity fillers run perfectly fine through a 30-gauge, allowing for delicate intradermal work without hand fatigue.
Exactly.
We're also seeing a massive shift toward blunt cannulas and automated injection devices in daily practice.
Yeah, they're becoming standard.
These tools reduce physician fatigue over a long clinic day, and theoretically, they dramatically decrease the risk of intravascular injection because a blunt tip will glide past and push a vessel aside rather than piercing the lumen.
Cannulas are fantastic for broad volume restoration, but delivery techniques vary heavily by the anatomical region and the instrument you're using.
Like the depot technique.
Right. A depot or bolus injection is great for supraperiosteal placement in the temporal hollow or the dorsum of the hands. You drop a bolus deep on the bone and then mold it manually.
And serial puncture is excellent for predictable, continuous lines along a discrete, righted, or redefining the vermilion border.
Exactly.
And then you have threading, fanning, and cross-hatching.
Yeah, these are linear retrograde or antegrade flows used for building up structural layers across a broader area, like the buccal hollows or the cheeks.
You use cross-hatching to literally weave a supportive interlocking mesh in the subcutaneous space.
Regardless of the technique, always use lidocaine with epinephrine.
Always.
The epi aggressively clamps down the local vasculature, which physically shrinks the target size of the vessels and further reduces your intravascular risk. It also gives you a bloodless field, minimizing bruising and post-procedural swelling.
Which your patients will absolutely thank you for.
Every time.
In real life, here is a clinical pearl you should use every single day. Immediately massage the area post-injection to ensure even distribution.
Yes.
Do not let the patient come back a week later with a palpable lump that you could have easily smoothed out on the table while the gel was still malleable.
Proper technique and immediate molding minimize those minor aesthetic risks. But, even with perfect execution, severe adverse events happen.
They do.
You need a rapid-fire protocol locked in your head for handling complications because when things go wrong, you have minutes to act.
The absolute nightmare scenario is immediate vascular compromise or impending necrosis.
It's terrifying.
You're injecting in a danger zone like the glabella, the supratrochlear artery, or the angular artery at the piriform aperture, and suddenly the skin blanches along a vascular distribution.
Or the patient reports a sharp, atypical pain that doesn't match the injection site at all.
You stop the injection immediately.
Do not wait to see if it improves. Initiate aggressive therapy right then. Apply gentle massage to try and mechanically clear the embolus.
And apply warm compresses to induce immediate vasodilation.
Administer oral aspirin. Apply 2% topical nitroglycerin paste directly to the ischemic area.
You aren't just applying nitroglycerin paste as a surface Band-Aid. It acts as a powerful nitric oxide donor to aggressively force smooth muscle relaxation in those ischemic capillary beds.
Right. And if you injected an HA, you immediately flood the area with massive doses of hyaluronidase. We are talking 500 to 1,000 units every hour.
You aren't just dissolving the product to break down the intravascular physical blockage.
No, you are degrading the extravascular gel to take the interstitial pressure off the collapsed vessel from the outside.
You can also inject low molecular weight heparin directly into the ischemic area to halt the progression of tissue necrosis.
It's a full court press. When we look at delayed complications occurring anywhere from a few weeks to 6 months out, it requires careful diagnostic work. You must differentiate between a physical technique error and a biological immune response.
Because the treatments are totally different.
Exactly. Nodules are usually a technique error. You placed the product too superficially, you didn't dilute it properly, or you injected a stiff, high G' product into highly mobile, dynamic tissue.
For a technique-induced nodule, you treat with aggressive massage, hyaluronidase if it is an HA, or simple incision and drainage.
Right.
For permanent fillers, you might be looking at outright surgical excision.
Unfortunately, yeah.
Granulomas, though, are an entirely different pathology.
A granuloma is a delayed cell-mediated immune response. The patient's body is actively walling off and attacking the material.
You treat granulomas by shutting down that local immune response with intralesional steroids, often combined with an antimetabolite like 5-fluorouracil to aggressively stop the cellular proliferation.
Right. And then you have biofilms.
Oh, biofilms.
These are rare, but they are devastating. A biofilm is a bacterial colony that secretes a sticky, protective polymer matrix around itself, adhering tightly to the foreign filler.
They can show up more than a year post-injection, presenting as recurrent, low-grade inflammatory nodules.
Yeah, and they require aggressive, prolonged oral antibiotics and often the complete removal or surgical washout of the infected filler material.
Here's a pointed clinical question for you, though. How do you actually differentiate between a delayed onset granuloma and a simmering biofilm in the clinic before you decide to inject steroids?
It's just tough.
Because if you blast an active biofilm with high-dose steroids, you are suppressing the local immune system and potentially making a localized infection exponentially worse.
You really have to look closely at the systemic picture and the clinical timeline. Granulomas often present as firm, non-fluctuant masses that flare up uniformly across all injected sites simultaneously.
Like everything swells at once.
Exactly. This is often triggered by a systemic viral illness or a vaccine that throws the immune system into overdrive.
Got it.
Biofilms, on the other hand, tend to be asymmetrical, fluctuant, and they may have overlying erythema that waxes and wanes over weeks.
So if you suspect a biofilm, or honestly, if you're even slightly unsure, you never inject steroids first. You start a broad-spectrum antibiotic trial, usually a macrolide or a tetracycline.
Yes. And if the nodule responds and shrinks on the antibiotics, you know you are dealing with a bacterial process.
Makes sense.
If it doesn't respond after an adequate course, you start considering a punch biopsy or culture to confirm a sterile granulomatous reaction before you ever reach for the Kenalog.
Mastering soft tissue fillers is clearly not just an aesthetic art. It is hardcore rheology, it is physics, and it is deep anatomical science.
You really have to respect the physical properties of the materials and the vascular architecture of the tissue equally.
And the field is moving incredibly fast. The cross-linked gels and biostimulators we use today are highly sophisticated, but we are still ultimately placing foreign synthetics into human tissue to trick the eye into seeing youth.
That's the reality of it.
Which leaves you with an interesting final thought to mull over. As our understanding of these highly separate facial fat compartments deepens, and our ability to isolate and grow cellular matrices improves, will the future of soft tissue fillers move away from synthetic gels entirely?
It's fascinating to think about.
Are we pushing toward engineered, lab-grown, autologous fat that permanently and seamlessly replaces exactly what was lost, right down to the cellular level? We might eventually stop trying to mimic tissue and just replace it. It brings us right back to where we started. We are no longer just chasing superficial wrinkles. We are chasing total structural regeneration.